trust is the foundation of care. But what happens when the very people we depend on to heal us become the architects of our destruction? In the sterile halls of a veterans hospital in West Virginia, patients arrived seeking treatment and left as victims of one of the most prolific serial killers in American history. Reta Mays was a trusted nursing assistant, a woman whose gentle demeanor and caring smile masked a darkness so profound it would claim the lives of 7 elderly veterans and attempt to steal away the lives of countless others. For years, Mays worked the night shift at the Louis A. Johnson Veterans Affairs Medical Center in Clarksburg. She was the kind of employee who seemed dedicated to her patients, someone families felt comfortable leaving their loved ones with during those vulnerable overnight hours. But behind her compassionate facade was a predator who had turned the act of caregiving into a weapon. Between 2017 and 2018, an alarming pattern began to emerge on the medical wards where Mays worked. Patients who had been stable, who were recovering from routine procedures or managing chronic conditions, would suddenly experience catastrophic drops in their blood sugar levels. These hypoglycemic episodes would send them into comas, cause seizures, and in many cases lead to their deaths. At first, the truth was as simple as it was monstrous. With diabetes who might naturally experience such dramatic patients with insulin, a medication that rapidly and blood sugar fluctuations. These were men whose bodies show after night. The same horrifying pattern repeated itself. Their dramatically lowers blood sugar. For a person, injection can be fatal, sending the body into shock and should not have been producing these life-threatening episodes. Yet Knight, who doesn't need insulin, and medical staff couldn't understand what Reta Mays was deliberately injecting her was happening. These were not patients sting down vital organs. She was using her position of trust and her access to medical supplies to systematically murder the men under her care. The victims were all elderly veterans, men who had served their country and deserved to spend their final years in safety and comfort. Instead, they became the targets of a woman who saw them not as human beings, but as opportunities to satisfy whatever dark compulsion drove her to kill. Robert Edge Sr. was 82 years old when he was admitted to the hospital for a routine procedure. He was expected to recover fully and return home to his family. Instead, after being in Mays' care, he suffered a sudden and unexpected hypoglycemic episode that sent him into a coma. He died shortly after, leaving his family devastated and confused about what had gone wrong. George Shaw, 81, had been managing his health conditions successfully when he was admitted for treatment. Like Edge, he experienced a sudden and severe drop in his blood sugar while under Mays' care. The episode was so severe it caused irreversible brain damage, and he died as a result of complications from the insulin poisoning. Felix McDermott, 82, Archie Edgell, 84, Raymond Golden, 88, Robert Kozel, 89, and Russell Posey, 92, all followed the same tragic pattern. Each man was vulnerable. Each was under Mays' care during the night shift, and each suffered the same type of suspicious medical episode that would ultimately claim their lives. But Mays' killing spree wasn't limited to these 7 confirmed victims. Investigators believe she attempted to murder many more patients with insulin injections, but some survived the attacks. The hospital records show a disturbing spike in unexplained hypoglycemic episodes during the period when Mays was working, suggesting that her reign of terror affected far more families than initially realized. The investigation into these suspicious deaths was triggered by the sheer number of unexpected medical emergencies occurring on Mays' shifts. Hospital administrators and federal investigators noticed that the pattern of hypoglycemic episodes was not random, but seemed to cluster around specific times and specific areas where Mays was working. When investigators began to dig deeper, they discovered that Mays had been systematically accessing insulin supplies that she had no legitimate reason to handle. Security footage and medical records painted a clear picture of a woman who was using her trusted position to obtain the means to kill her patients. The motive behind Mays's actions remains one of the most chilling aspects of her crimes. Unlike some healthcare serial killers who claim they were trying to end suffering or who killed in moments of stress or breakdown, Mays appeared to kill simply because she could. There was no evidence that she was motivated by mercy or that she was responding to any external pressures. She seemed to derive some form of satisfaction from having the power to decide who lived and who died. During her confession to federal investigators, Mays admitted to deliberately administering insulin to patients who did not need it, knowing that it could cause serious harm or death. She showed little emotion as she described her actions, displaying a chilling detachment from the magnitude of her crimes. Her method was particularly insidious because insulin, while life-saving for diabetics, can be virtually undetectable as a murder weapon when used on non-diabetic patients. The symptoms of insulin poisoning can mimic other medical emergencies, making it an ideal choice for someone looking to kill without detection. Mays exploited this medical blind spot to carry out her murders over an extended period. The families of her victims were left not only to grieve their losses, but to grapple with the horrifying realization that their loved ones had been deliberately murdered by someone they trusted. These men had survived wars, raised families, and lived full lives, only to be killed by a woman who was supposed to be caring for them in their final years. The impact on the veteran community was particularly profound. These were men who had served their country with honor, who had earned the right to quality healthcare through their military service. The betrayal of that trust by someone within the very system designed to care for them added an extra layer of tragedy to their deaths. In 2020, Reta Mays pleaded guilty to 7 counts of second-degree murder and 1 count of assault with intent to commit murder. She was sentenced to 7 consecutive life sentences, ensuring that she would never again have the opportunity to harm vulnerable patients. During her sentencing, the families of her victims were given the opportunity to address the court and speak directly to the woman who had stolen their loved ones from them. Their statements were heartbreaking testimonies to the lives that had been cut short and the trust that had been so brutally violated. The case prompted a comprehensive review of security protocols at VA hospitals across the country. New safeguards were implemented to monitor medication access and to flag unusual patterns of patient emergencies. The goal was to ensure that no other healthcare worker would be able to use their position to harm the patients they were sworn to protect. But the psychological impact of Mays' crimes extends far beyond policy changes and security measures. She shattered the fundamental trust that must exist between patients and their caregivers. Every family member who leaves a loved one in the care of medical professionals must now carry the knowledge that monsters can hide behind scrubs and caring smiles. As of today, Reta Mays remains incarcerated, serving her life sentences in federal prison. She will never be eligible for parole, never again walk free, and never again have access to vulnerable patients. But for the families of Robert Edge Sr., George Shaw, Felix McDermott, Archie Edgell, Raymond Golden, Robert Kozel, and Russell Posey, no amount of justice can bring back the men they lost to her calculated cruelty. The case of Reta Mays stands as one of the most shocking examples of healthcare serial killing in American history, a reminder that evil can lurk in the most unexpected places and wear the most trusted faces. The hospital should be a sanctuary of healing, but for countless patients across America, it became their final destination at the hands of those sworn to protect them. In the quiet corridors of Northampton County Nursing Home in Pennsylvania, residents and their families believed they had found a safe haven for their most vulnerable years. But between 1987 and 1988, that sanctuary became a hunting ground for one of the most cold-blooded predators in healthcare history. Her name was Dorothea Puente, and she would transform the act of caregiving into systematic murder. Puente appeared to be the ideal caregiver. She was soft-spoken, grandmotherly, and seemed genuinely concerned about the welfare of her elderly charges. She had worked in various healthcare facilities throughout her career, always presenting herself as someone who had dedicated her life to helping others. But beneath her nurturing exterior was a calculating killer who saw her patients not as human beings deserving of care, but as obstacles to be eliminated for her own twisted purposes. The deaths began slowly, almost imperceptibly. Elderly residents who had been stable would suddenly take dramatic turns for the worse. They would complain of feeling unwell, experience difficulty breathing, and within hours or days, they would be dead. At first, the deaths were attributed to the natural course of aging and illness. After all, these were frail, elderly individuals living in a nursing home. Death was not unexpected in such an environment. But as the months passed, the pattern became impossible to ignore. The mortality rate on Puente's shifts was significantly higher than normal. Residents who had been managing their conditions successfully would suddenly deteriorate when she was on duty. Family members began to notice that their loved ones seemed more confused, more lethargic, and more distressed after spending time with Puente. The truth was as simple as it was horrifying. Puente was systematically poisoning her patients with a combination of medications and toxic substances that she would slip into their food or medications. Her method was particularly insidious because she used substances that were difficult to detect in standard autopsies, especially in elderly patients who might naturally have complex medical conditions. Her victims included Dorothea Miller, 78, who had been living comfortably in the facility until she began complaining of severe stomach pain and nausea after meals that Puente had prepared or served. Within days, Miller was dead, her body ravaged by what appeared to be a sudden and aggressive illness that doctors couldn't fully explain. Benjamin Fink, 85, had been a vibrant resident who enjoyed spending time with other patients and participating in facility activities. After several encounters with Puente, he became increasingly withdrawn and complained of feeling dizzy and weak. His condition deteriorated rapidly, and he died under circumstances that his family found deeply suspicious. Ruth Monroe, 61, was younger than many of the facility's residents and had been admitted for rehabilitation following a minor surgery. She was expected to recover fully and return to independent living. Instead, after being under Puente's care for just 2 weeks, she died suddenly from what appeared to be complications that made no medical sense given her previous condition. The investigation into these suspicious deaths was launched after several family members independently approached administrators with concerns about the care their loved ones had received. They described similar patterns of sudden illness, complaints about food tasting strange, and rapid deterioration that seemed to coincide with Puente's presence. When investigators began examining the facility's records, they discovered that Puente had been working at the nursing home under false credentials. Her background check had not been properly conducted, and had it been, it would have revealed a criminal history that should have immediately disqualified her from working in healthcare. Puente had been previously convicted of theft and fraud, charges that stemmed from her practice of befriending elderly individuals, gaining their trust, and then stealing from them. She had served time in prison for these crimes, but had managed to obtain employment at the nursing home by lying about her past and forging references. The deeper investigators dug, the more horrifying the truth became. Puente had not simply been stealing from her victims, though evidence showed she had been systematically robbing residents of their personal belongings and social security checks. She had been killing them to cover up her thefts and to eliminate witnesses who might expose her criminal activities. Her method of murder was particularly cruel because it involved a prolonged period of suffering for her victims. Rather than killing them quickly, she would poison them slowly over days or weeks, causing them to experience severe pain, confusion, and distress before finally succumbing to the toxic substances she had been feeding them. The forensic investigation revealed that Puente had been using a combination of prescription medications that she had stolen from the facility's pharmacy, mixed with household poisons and plant toxins that were nearly impossible to detect without specialized testing. She had researched methods of poisoning that would mimic natural illness in elderly patients, making her crimes extremely difficult to identify. When confronted with the evidence, Puente initially denied any wrongdoing, claiming that she was being persecuted because of her previous criminal record. She insisted that the deaths were natural and that she had only been trying to provide comfort to dying patients. But as the evidence mounted, her story began to fall apart. Investigators found that she had been forging medical records to cover up the symptoms her victims had experienced before their deaths. She had been disposing of evidence by throwing away medication containers and cleaning supplies that she had used to prepare her poison mixtures. Most damning of all, they found a notebook in her possession that contained detailed information about various toxic substances and their effects on the human body. The trial of Dorothea Puente became a media sensation, not only because of the shocking nature of her crimes, but because of the vulnerability of her victims and the betrayal of trust that her actions represented. The prosecution portrayed her as a remorseless predator who had preyed upon the most defenseless members of society for her own financial gain. The families of her victims testified about the horror of losing their loved ones to someone they had trusted to provide care and comfort. They described the devastating realization that their family members had not died peacefully from natural causes, but had been slowly tortured to death by a woman who had pretended to care about their well-being. The defense attempted to portray Puente as a troubled woman who had been trying to help her patients and had made tragic mistakes in her care. They argued that she had been overwhelmed by the demands of her job and had been self-medicating her patients in misguided attempts to ease their suffering. But the evidence of premeditation and the systematic nature of her crimes made this defense untenable. In 1989, Dorothea Puente was convicted of multiple counts of first-degree murder and sentenced to death. Her case became a landmark in the prosecution of healthcare serial killers and led to significant changes in background check procedures for healthcare workers across the country. The impact of her crimes extended far beyond the immediate victims and their families. The entire nursing home industry was forced to confront the reality that predators could infiltrate their facilities and use their positions of trust to harm the very people they were supposed to protect. New protocols were implemented for medication management, employee monitoring, and family communication to prevent similar tragedies from occurring. But perhaps the most lasting damage was to the fundamental trust that families must have when placing their loved ones in care facilities. Puente had exploited the natural vulnerability of elderly patients and the trust of their families to carry out her murderous scheme. Her actions created a climate of fear and suspicion that continues to affect the healthcare industry today. As of today, Dorothea Puente remains on death row, her case serving as a chilling reminder that those we trust most with our vulnerable loved ones can sometimes be the very people we should fear. But the horrors of healthcare predators extend far beyond the walls of nursing homes and hospitals. Sometimes, the most trusted caregivers are those who work directly in our communities, in our homes, providing intimate care to those who need it most. In the quiet suburban neighborhoods of Connecticut, families believed they had found the perfect solution for caring for their aging parents and disabled family members. Home healthcare workers promised personalized, compassionate care in the comfort and familiarity of the patient's own home. But for several families between 2003 and 2004, that promise became a nightmare when they unknowingly invited a killer into their most sacred spaces. Amy Archer appeared to be everything a family could want in a home healthcare aide. She was professional, experienced, and came with glowing references from previous employers. She specialized in caring for elderly patients and those with chronic medical conditions, presenting herself as someone who had dedicated her career to helping the most vulnerable members of society. Families felt fortunate to have found someone so qualified and caring to tend to their loved ones. But Archer was not the angel of mercy she pretended to be. She was a predator who had discovered that the isolation of home healthcare provided the perfect cover for her murderous activities. Unlike hospital or nursing home settings where multiple staff members might witness suspicious behavior, home healthcare placed her alone with vulnerable patients for hours at a time, with no oversight and no witnesses to her crimes. Her first known victim was Harold Davis, a 78-year-old retired teacher who had hired Archer to help manage his diabetes and provide general assistance with daily activities. Davis had been living independently and managing his condition successfully for years before Archer entered his life. His family had arranged for her services because they wanted to ensure he had professional support while maintaining his independence in his own home. Within weeks of Archer beginning her care, Davis's condition began to deteriorate rapidly. He complained to his daughter that he was experiencing severe episodes of dizziness and confusion that seemed to come out of nowhere. His blood sugar levels became increasingly unstable, swinging wildly between dangerous highs and catastrophic lows despite his normally well-controlled diabetes management routine. The episodes always seemed to occur when Archer was present or shortly after her visits. She would express deep concern about Davis's declining condition, suggesting that his diabetes was progressing more rapidly than expected and that he might need more intensive medical intervention. She positioned herself as his advocate, the one person who truly understood the severity of his condition. What Davis and his family didn't realize was that Archer was deliberately manipulating his insulin levels, injecting him with massive doses of the medication when he didn't need it and withholding it when he did. She was creating the very medical crises she pretended to be so concerned about, pushing his body into a state of constant metabolic chaos. The end came suddenly and brutally. During what should have been a routine morning visit, Archer administered a massive overdose of insulin to Davis, sending him into severe hypoglycemic shock. When his daughter arrived for her daily check-in, she found her father unconscious on his bedroom floor, with Archer supposedly performing CPR and frantically calling for emergency services. Davis died en route to the hospital, his body unable to recover from the catastrophic metabolic disruption Archer had inflicted. The official cause of death was listed as complications from diabetes, a conclusion that seemed reasonable given his medical history. His family grieved what they believed was the natural progression of his illness, never suspecting that he had been murdered by the woman they had trusted to care for him. Emboldened by her success and the lack of suspicion surrounding Davis's death, Archer moved on to her next victim. Margaret Coleman was an 82-year-old widow who lived alone but needed assistance managing multiple medications for her heart condition and arthritis. Her son had hired Archer to visit daily, help organize her medications, and provide companionship for his increasingly isolated mother. Coleman had been stable on her medication regimen for years, with regular cardiology appointments showing that her heart condition was well controlled. But after Archer began caring for her, she started experiencing episodes of severe chest pain, shortness of breath, and dangerous fluctuations in her heart rhythm. Archer's method with Coleman was different, but equally deadly. She began tampering with the elderly woman's heart medications, sometimes giving her double or triple doses of powerful cardiac drugs, other times skipping doses entirely. She would also mix incompatible medications together, creating dangerous drug interactions that sent Coleman's cardiovascular system into chaos. Like with Davis, Archer positioned herself as Coleman's concerned advocate, accompanying her to doctor's appointments and expressing worry about her declining condition. She kept detailed notes about Coleman's symptoms, painting a picture of a woman whose health was failing despite the best medical care. The doctors, seeing Archer's apparent dedication and detailed documentation, had no reason to suspect that she was the cause of the very problems she was so carefully chronicling. Coleman's death was even more dramatic than Davis's. During what Archer later claimed was a routine medication administration, Coleman suddenly collapsed, clutching her chest and gasping for air. Archer called 911, reporting that her patient was experiencing what appeared to be a massive heart attack. The paramedics found Coleman in full cardiac arrest, her heart rhythm completely chaotic and unresponsive to standard resuscitation attempts. Despite aggressive treatment in the emergency room, she was pronounced dead within an hour of the initial episode. The attending physician attributed her death to sudden cardiac failure, a not uncommon occurrence in elderly patients with pre-existing heart conditions. What the medical team didn't know was that Archer had administered a lethal cocktail of Coleman's heart medications mixed with other drugs she had stolen from previous patients. The combination had essentially poisoned Coleman's cardiovascular system, causing the very heart attack that had killed her. Archer's third victim was Robert Mitchell, a 69-year-old man who was recovering from a stroke and needed assistance with physical therapy and medication management. Mitchell had been making steady progress in his recovery when his family hired Archer to provide additional support during his rehabilitation. The stroke had left Mitchell partially paralyzed and with some cognitive impairment, making him particularly vulnerable to abuse. He had difficulty communicating clearly and often struggled to remember recent events, conditions that Archer exploited ruthlessly in her campaign to kill him. She began by gradually increasing his blood pressure medications to dangerous levels while simultaneously withholding the blood thinners that were crucial for preventing another stroke. The combination created a perfect storm in Mitchell's already compromised cardiovascular system, making another stroke virtually inevitable. But Archer wasn't content to wait for the natural progression of her sabotage. She began adding additional medications to Mitchell's routine, drugs that she had no legitimate reason to administer and that created dangerous interactions with his prescribed treatments. She told his family that the doctor had recommended these additional medications to speed his recovery, forging documentation to support her lies. Mitchell's condition deteriorated rapidly under Archer's care. He began experiencing severe headaches, confusion, and episodes of slurred speech that his family assumed were related to his original stroke. What they didn't realize was that these were symptoms of the systematic poisoning Archer was subjecting him to. The final assault came during what Archer described as a routine physical therapy session. She administered a massive dose of blood pressure medication combined with several other drugs that she had been secretly giving Mitchell for weeks. The combination caused his blood pressure to drop precipitously while simultaneously triggering a massive stroke that destroyed much of his remaining brain function. Mitchell lingered in a coma for several days before dying, his brain too damaged to sustain life. His death was attributed to complications from his original stroke, with doctors noting that such outcomes were unfortunately common in stroke patients. His family mourned what they believed was the tragic but natural end to his struggle to recover from his initial medical crisis. The pattern might have continued indefinitely, if not for the suspicious observations of a sharp-eyed pharmacy technician who noticed that Archer was filling prescriptions for multiple patients who seemed to be receiving similar combinations of medications. The technician was particularly concerned because some of the medication combinations were potentially dangerous and didn't seem to match the typical prescribing patterns for the conditions Archer claimed her patients had. When the technician contacted the prescribing physicians to verify the prescriptions, several doctors reported that they had never prescribed those particular medications for those patients. The investigation that followed quickly revealed that Archer had been forging prescriptions and stealing medications from various sources to use in her murderous schemes. The forensic investigation into the deaths of Davis, Coleman, and Mitchell revealed the horrifying truth about their final days. Toxicology tests that had not been performed during the initial autopsies showed lethal levels of various medications in their systems, combinations that could not have occurred naturally or through legitimate medical treatment. Investigators also discovered that Archer had been systematically stealing from her victims, taking jewelry, cash, and valuable items from their homes, while they were too ill to notice or too impaired to report the thefts. She had been using her position of trust, not only to kill her patients, but to rob them as well, adding financial gain to whatever psychological satisfaction she derived from her murders. When confronted with the overwhelming evidence of her crimes, Amy Archer initially maintained her innocence, claiming that she was being falsely accused because of coincidental deaths among her elderly patients. She insisted that she had been a dedicated caregiver who had simply been unlucky to lose multiple patients in a short period of time. But as investigators pieced together the evidence of forged prescriptions, stolen medications, and the systematic nature of the deaths, her story began to crumble. The breakthrough came when investigators discovered Archer's detailed journal, hidden in her apartment, which contained meticulous records of each patient's medication schedule, their reactions to various drugs, and what appeared to be experimental notes about different combinations of medications and their effects. The journal read like a scientist's lab notes, documenting her victims' suffering with clinical detachment. Most chilling of all were the entries where she described her victims' final moments, writing about their confusion, their pain, and their trust in her even as she was killing them. She seemed to derive a perverse satisfaction from their helplessness and from the grief of their families, who never suspected that their loved ones' deaths were anything other than natural. The trial of Amy Archer sent shockwaves through the home healthcare industry. The prosecution painted a picture of a woman who had weaponized the most intimate form of medical care, turning the sanctuary of home into a killing ground. They argued that she had specifically chosen home healthcare because it provided her with the perfect hunting ground, isolated victims with no witnesses and minimal oversight. The families of her victims testified about their devastating realization that they had unknowingly hired their loved one's killer. They described the guilt they felt for bringing this monster into their parents' homes, for trusting someone who had used that trust to commit murder. Their testimony was heartbreaking, revealing not just the loss of their family members, but the destruction of their faith in the entire concept of home healthcare. In 2005, Amy Archer was convicted of 3 counts of first-degree murder and sentenced to life in prison without the possibility of parole. Her case led to sweeping reforms in the home healthcare industry, including mandatory background checks, regular supervision requirements, and strict medication management protocols. But the psychological damage extended far beyond policy changes. Archer had violated the most sacred trust that exists in healthcare, the belief that those who come into our homes to care for our most vulnerable family members will protect them rather than harm them. Her crimes created a lasting climate of fear that continues to affect families who need home healthcare services today. As of now, Amy Archer remains imprisoned, serving her life sentence in a maximum security facility. But her legacy lives on in the shattered trust of countless families who must now view every caregiver with suspicion, wondering if the person they're inviting into their home to help their loved one might actually be planning to harm them. The sterile environment of a hospital intensive care unit should represent the pinnacle of medical care, where the sickest patients receive the most advanced treatment from the most skilled professionals. But in the cardiac care unit of Glendale Adventist Medical Center in California, patients fighting for their lives found themselves at the mercy of a killer who had turned the tools of healing into instruments of death. Ephen Salivar was a respiratory therapist, a medical professional specifically trained to help patients breathe and maintain their vital functions during critical illness. For over a decade, from 1989 to 1998, he worked in the hospital's intensive care units, earning a reputation among his colleagues as someone who was always present during medical emergencies, always ready to help when a patient took a turn for the worse. What his colleagues didn't realize was that Salivar wasn't responding to medical emergencies, he was creating them. Behind his professional demeanor and apparent dedication to his patients was a predator who had discovered that his position gave him unprecedented access to vulnerable patients and the means to kill them without detection. Salivar's method was particularly insidious because he used his legitimate medical knowledge and access to turn standard medical equipment into murder weapons. As a respiratory therapist, he had routine access to patients' ventilators, oxygen supplies, and breathing apparatus. He also had legitimate reasons to be alone with critically ill patients for extended periods, administering treatments that other staff members wouldn't question or supervise closely. His first known victim was Luina Szydlowski, an 87-year-old woman who had been admitted to the cardiac intensive care unit for monitoring after experiencing chest pains. Her condition was stable, and doctors expected her to recover fully with proper cardiac care. She was alert, speaking with her family, and showing good signs of improvement when Salivar was assigned to her care. During what should have been a routine respiratory treatment, Salivar administered a lethal injection of succinylcholine, a powerful muscle relaxant used during medical procedures to temporarily paralyze patients. In controlled medical settings, succinylcholine is life-saving, allowing doctors to perform intubations and surgeries safely. But when administered inappropriately, it causes complete paralysis while leaving the victim fully conscious and aware of what is happening to them. Szydlowski experienced the ultimate horror of being fully awake but completely unable to move, speak, or breathe as the drug coursed through her system. She would have been aware that she was dying, aware that someone was killing her, but completely unable to call for help or fight back. The paralysis made it impossible for her to signal distress, and to observers, she would have simply appeared to be resting peacefully. As the succinylcholine took effect, Szydlowski's breathing became labored and then stopped entirely. Salivar, playing his role as the concerned respiratory therapist, immediately called for emergency assistance, claiming that his patient had suddenly gone into respiratory distress. The medical team responded quickly, but despite their best efforts, they were unable to revive her. The cause of death was listed as respiratory failure, secondary to cardiac complications, a not uncommon occurrence in elderly patients with heart conditions. No one suspected that Szydlowski had been murdered because succinylcholine breaks down rapidly in the body and is virtually undetectable in standard post-mortem examinations, unless investigators know specifically to look for it. Emboldened by his success and the complete lack of suspicion, Salivar continued his killing spree. His next victim was Jose Alfaro, a 52-year-old construction worker who'd been admitted to the hospital after suffering a heart attack. Alfaro had survived the initial cardiac event and was responding well to treatment when he was placed under Salivar's care. Like Szydlowski, Alfaro was alert and communicating with his family when Salivar entered his room during the night shift. Using the same method, Salivar injected him with succinylcholine, causing complete paralysis while leaving him fully conscious. Alfaro would have experienced the terror of being unable to breathe while watching his killer calmly prepare the scene to make his death appear natural. The pattern was always the same. Salivar would wait until he was alone with his victim, administer the lethal injection, and then call for help when the patient went into distress. He became known among his colleagues as someone who was always present during medical emergencies, someone who seemed to have an uncanny ability to be nearby when patients took sudden turns for the worse. What his colleagues interpreted as dedication and quick response was actually Salivar's carefully orchestrated murder routine. He was always nearby because he was the one creating the emergencies. He was always ready to help because he had planned every detail of his victims' deaths. The murders continued for years, with Salivar claiming victim after victim in the cardiac and intensive care units. Maria Hernandez, 78, died after experiencing sudden respiratory failure during what should have been a routine breathing treatment. Roberto Santos, 65, went into cardiac arrest just hours after showing signs of improvement from his surgery. Elena Rodriguez, 71, stopped breathing unexpectedly while recovering from a minor procedure. Each death followed the same pattern, each victim experiencing the same terrifying final moments of paralysis and awareness, as Salivar systematically murdered them with the very medical equipment meant to save their lives. And each time, he played the role of the concerned healthcare professional, expressing appropriate sadness at the loss of his patients, while secretly planning his next kill. The investigation that would eventually expose Saldivar's crimes began not with a single suspicious death, but with a statistical analysis that revealed an alarming pattern. Hospital administrators conducting a routine review of mortality rates noticed that deaths in the respiratory therapy department had increased significantly over the past several years, with an unusually high number of unexpected deaths occurring during night shifts. When investigators began examining the circumstances surrounding these deaths, they discovered that Saldivar had been present for an extraordinary number of patient deaths, far more than would be statistically normal for any healthcare worker. They also noticed that many of the deaths involved patients who had been stable or improving before suddenly experiencing catastrophic respiratory or cardiac events. The breakthrough came when investigators decided to exhume the bodies of several patients who had died under suspicious circumstances while in Saldivar's care. Advanced toxicological testing revealed traces of succinylcholine in tissue samples, providing the first concrete evidence that these patients had been murdered. When confronted with this evidence, Saldivar initially denied any wrongdoing, claiming that the presence of succinylcholine could be explained by legitimate medical treatments. But as investigators presented him with the overwhelming statistical evidence of his presence at so many deaths, combined with the forensic proof of poisoning, his story began to fall apart. In a stunning confession that shocked the medical community, Saldivar admitted to killing over 50 patients during his decade-long career at Glendale Adventist Medical Center. He described in chilling detail how he had selected his victims, how he had administered the lethal injections, and how he had covered his tracks by making the deaths appear natural. His motive, he claimed, was a twisted form of mercy killing. He said he had convinced himself that he was ending the suffering of patients who were in pain or who had poor prognoses. But investigators found no evidence to support this claim. Many of his victims had been recovering well and were expected to return home to their families. His actions appeared to be motivated not by mercy, but by a sadistic desire to control life and death. The scope of Saldivar's crimes made him one of the most prolific serial killers in American history. The families of his victims were devastated, not only by their losses, but by the realization that their loved ones had been deliberately murdered by someone they had trusted to provide care. Many described the additional trauma of knowing that their family members had died in terror and pain, fully aware that they were being killed, but unable to fight back or call for help. The investigation also revealed that there had been warning signs that went unheeded. Several nurses had noticed that Saldivar seemed to be present at an unusual number of patient deaths, and some had informally commented on the pattern. But the hospital's administration had not followed up on these observations, and no formal investigation had been conducted until years later. In 2002, Ephen Salivar was convicted of 6 counts of murder, though investigators believe he may have killed dozens more patients whose deaths were never thoroughly investigated. He was sentenced to life in prison without the possibility of parole, ensuring that he would never again have access to vulnerable patients. The case prompted widespread reforms in hospital protocols for monitoring medication access and tracking unusual patterns of patient deaths. Hospitals across the country implemented new systems for detecting statistical anomalies that might indicate criminal activity, and respiratory therapy departments were. But the psychological impact subject to increased oversight and supervision of Saldivar's crimes extends far beyond policy changes. He violated the fundamental trust that patients and families place in healthcare professionals, particularly those who work with the sickest and most vulnerable patients. His actions created lasting trauma, not only for the families of his victims, but for the entire medical community, which had to confront the reality that predators could infiltrate their ranks and use their medical knowledge to commit murder. The case also highlighted the particular vulnerability of patients in intensive care settings, where they are often sedated, intubated, or otherwise unable to communicate. These patients depend entirely on their caregivers for survival, making them perfect targets for someone intent on causing harm. As of today, Ephen Salivar remains imprisoned, serving his life sentence while the families of his victims continue to struggle with the knowledge that their loved ones died, not from natural causes or medical complications, but from the deliberate actions of a man they had trusted to help them heal. The betrayal of trust that defines these cases reaches its most intimate and devastating form when the killer is not just a caregiver, but a family member entrusted with the most sacred duty of all, protecting and nurturing a child. In the quiet suburban community of Scottsville, New York, a young mother named Beth Tinning appeared to be living through every parent's worst nightmare. Over the course of 14 years, from 1972 to 1985, she would bury 9 of her children, each death seemingly the result of tragic medical conditions or sudden infant death syndrome. The community rallied around Tinning and her husband Joseph, offering support and sympathy as they endured loss after unimaginable loss. Neighbors, friends, and family members saw them as a couple, cursed by terrible luck, parents who deserved compassion rather than suspicion as they struggled to cope with their devastating string of tragedies. But the truth was far more sinister than anyone could have imagined. Beth Tinning was not the victim of cruel fate or medical misfortune. She was a serial killer who had turned motherhood itself into a weapon, systematically murdering her own children to satisfy her desperate need for attention and sympathy. Her first victim was her own 8-week-old daughter, Jennifer, who died in 1972 from what appeared to be meningitis. The medical examiner found nothing suspicious about the infant's death, and the community mourned with the young parents who had lost their first child to a tragic illness. But Jennifer's death was not the result of natural causes. Beth had smothered her daughter, then waited for the right moment to discover the body and call for help. The attention and sympathy that followed Jennifer's death became an addiction for Beth. She found herself craving the concerned visits from neighbors, the gentle embraces from church members, and the special status that came with being a grieving mother. When the initial wave of sympathy began to fade, she began planning her next tragedy. Joseph Jr., born in 1973, lived for just 2 weeks before succumbing to what doctors diagnosed as sudden infant death syndrome. Again, there was no suspicion of foul play. SIDS was a recognized medical phenomenon that claimed the lives of seemingly healthy infants, and the Tinning family received another outpouring of community support as they buried their second child. But Joseph Jr. had not died from SIDS. Like his sister before him, he had been deliberately smothered by his mother, who had carefully waited until she was alone with the infant before placing a pillow over his face and holding it there until he stopped breathing. She then placed his body back in his crib and waited several hours before discovering him and calling emergency services. The pattern continued with Barbara, born in 1975, who lived for 4 months before dying from what appeared to be Ray's syndrome. Then came Timothy in 1973, who died at 4 months from what doctors attributed to sudden infant death syndrome. Nathan followed in 1975, dying at 5 months from pulmonary edema. Mary Frances lived for 4 months in 1978, before succumbing to SIDS. Jonathan survived for only 2 months in 1980, before dying from what appeared to be respiratory failure. Each death followed the same horrifying pattern. Beth would wait until she was alone with the child, then systematically suffocate them using pillows, plastic bags, or simply her hands pressed over their tiny faces. She became expert at timing the murders to coincide with periods when her husband was at work or otherwise occupied, ensuring that she would be the one to discover each body. After each murder, she would perform an elaborate charade of grief and shock. She would call emergency services, sobbing hysterically into the phone about finding her baby unresponsive. When paramedics arrived, they would find her cradling the lifeless infant, tears streaming down her face as she begged them to save her child. The medical professionals who responded to these calls saw exactly what Mary Beth wanted them to see: a devastated mother experiencing every parent's worst nightmare. The deaths occurred in an era when sudden infant death syndrome was poorly understood, making it easier for multiple infant deaths in the same family to be attributed to genetic factors or environmental causes, rather than deliberate murder. Between the deaths of her biological children, Mary Beth also cared for several foster children and adopted children. Remarkably, none of these children died while in her care. This pattern should have raised red flags for investigators, as it suggested that whatever was causing the deaths of her biological children was not affecting the other children in her home. But the significance of this pattern went unnoticed for years. The community continued to rally around the Tinning family with each new tragedy. Church members organized meal trains and fundraisers to help with funeral expenses. Neighbors offered to babysit their surviving children and provide emotional support during their times of grief. Local newspapers wrote sympathetic articles about the family's struggles, portraying them as victims of extraordinary misfortune. What no one realized was that Mary Beth was not just enduring these tragedies, she was orchestrating them. Each funeral became a performance where she could bask in the attention and sympathy of the entire community. She memorized the words that would elicit the most compassionate responses, learned to time her emotional breakdowns for maximum impact, and carefully cultivated an image of a mother struggling bravely against impossible odds. The investigation that would eventually expose her crimes began with the death of her daughter, Tammy Lynn, in 1985. Unlike her previous children, Tammy Lynn had survived to the age of 4 months and had been seen by multiple doctors for various health issues. When she died suddenly at home, one of her pediatricians became suspicious about the circumstances surrounding her death. Dr. Thomas Oram had been treating Tammy Lynn for minor health issues and had found her to be a normal, healthy infant with no life-threatening conditions. When he learned of her sudden death, he was troubled by the discrepancy between her apparent good health and her unexpected demise. More concerning still was when he learned about the family's history of infant deaths. Dr. Oram contacted the medical examiner's office and requested a thorough investigation into Tammy Lynn's death. When investigators began examining the family's medical history, they were shocked to discover the extent of the tragedy that had befallen the Tinning family. 9 children dead over the course of 13 years was statistically impossible unless there was an underlying cause that had gone undetected. The forensic investigation into Tammy Lynn's death revealed evidence of suffocation. Tissue samples showed signs of oxygen deprivation that were consistent with smothering rather than natural causes of death. Armed with this evidence, investigators obtained court orders to exhume the bodies of several of the other Tinning children. The results were horrifying. Multiple children showed evidence of suffocation or smothering, with tissue damage patterns that could not be explained by natural causes or the various medical conditions that had been listed on their death certificates. The forensic evidence painted a clear picture of systematic murder committed by someone with intimate access to the children. When confronted with this evidence, Mary Beth initially maintained her innocence, claiming that she was being persecuted for having the misfortune of losing so many children to natural causes. She insisted that she was a loving mother who had done everything possible to save her babies, and that the accusations against her were adding unbearable pain to her already overwhelming grief. But as investigators continued to build their case, presenting her with the forensic evidence and the statistical impossibility of so many deaths occurring naturally in one family, her story began to crumble. The breakthrough came when investigators offered her the opportunity to confess in exchange for a more lenient sentence. In a stunning admission that sent shockwaves through the community that had supported her for over a decade, Mary Beth Tinning confessed to murdering 3 of her children: Tammy Lynn, Timothy, and Nathan. She claimed that she had been overwhelmed by the demands of motherhood and had acted impulsively during moments of extreme stress and exhaustion. Her confession, crafted to minimize, however, was carefully her culpability and maintain some sympathy from the public. She admitted only to the deaths for which investigators had the strongest forensic evidence, and she portrayed herself as a mentally ill woman who had acted out of desperation rather than calculation. The reality, as investigators would later piece together, was far more disturbing. Mary Beth had been methodically planning and executing the murders of her children for over a decade. She had researched methods of suffocation that would be difficult to detect, had carefully timed each murder to avoid witnesses, and had perfected her performance as a grieving mother to deflect suspicion. The trial of Mary Beth Tinning became one of the most sensational criminal cases in New York State history. The prosecution argued that she was a cold and calculating killer who had murdered her own children to satisfy her pathological need for attention and sympathy. They presented evidence showing that she had thrived on the attention that came with each tragedy, becoming animated and energized during the funeral proceedings and community support efforts. The defense attempted to portray her as a mentally ill woman who had been driven to desperate acts by postpartum depression and the overwhelming stress of caring for multiple children. They argued that she was not a calculating killer, but a sick woman who needed treatment rather than punishment. The families of the victims, ironically, were not just the extended relatives who had lost their nieces and nephews, but the entire community that had been manipulated and deceived by Mary Beth's elaborate charade. Neighbors who had provided meals and emotional support felt violated by the realization that they had been unknowingly enabling a serial killer. Church members who had prayed for the family and contributed to funeral expenses struggled with the knowledge that their compassion had been exploited by a murderer. Perhaps most devastating of all was the impact on Joseph Tinning, Mary Beth's husband, who had genuinely grieved the loss of each child while living with their killer. The realization that his wife had been systematically murdering their children while he mourned them as natural tragedies created a psychological trauma that would haunt him for the rest of his life. In 1987, Mary Beth Tinning was convicted of second-degree murder in the death of Tammy Lynn and sentenced to 20 years to life in prison. Though she was only convicted for one murder due to the statute of limitations on some of the earlier deaths, investigators believe she was responsible for the deaths of all 9 children who died in her care. The case fundamentally changed how medical professionals and law enforcement approach cases of multiple infant deaths within the same family. New protocols were established requiring immediate investigation when more than 2 children in the same household die of unexplained causes. Medical examiners were trained to look for subtle signs of suffocation that might have been missed in earlier eras. But perhaps the most lasting impact was on the concept of maternal trust itself. Mary Beth Tinning had weaponized motherhood, turning the most fundamental relationship in human society into a tool for murder. Her crimes forced society to confront the unthinkable reality that the person most trusted to protect a child could also be the greatest threat to that child's life. The psychological profile that emerged from her case became a template for understanding other cases of maternal filicide. Investigators learned to look for patterns of attention-seeking behavior, inconsistencies in medical histories, and the statistical impossibility of multiple unexplained deaths in the same household. As of today, Mary Beth Tinning remains incarcerated, having been denied parole multiple times. Each parole hearing brings renewed attention to her crimes and fresh pain for the community that was deceived by her elaborate performance of grief. Her case stands as one of the most chilling examples of how the nurturing instinct can be perverted into its complete opposite, turning a mother from protector into predator. From the hospital wards where heroes once healed to the homes where love should have flourished, these women transformed the most sacred bonds of trust into weapons of destruction. They remind us that evil doesn't always announce itself with obvious warning signs, but can hide behind the gentlest smiles, the most caring gestures, and the most trusted positions in our society, forever changing how we view those who hold our lives in their hands.